Mealtime, a time to relax, to enjoy, a social occasion. How we eat can be as important as what we eat, especially as we age. That's why, even as we get older, food and the dining experience remain a source of happiness and satisfaction. Think about it. Do you have a favorite food? A favorite mealtime memory? Good nutrition is crucial to our well-being. When residents have dementia, it can be difficult for them to get the nutrition they need and to enjoy meals in the same way they might have in the past. Unfortunately, dementia has become widespread. It touches each of us through a family member, a friend, and almost certainly through the residents in our care. As caregivers, we can help residents make mealtime meaningful and ensure that they are well nourished, that eating provides the sustenance for living. But our job can be challenging.
What is this?
You asked for French toast.
But I don't like it. It doesn't taste right. I'm not hungry.
Here you go, Dorothy. Thank you.
Come on, Mr. Heckler, please. It's time for dinner.
No, no, no.
Dementia poses special challenges for residents and caregivers. It certainly interferes with self-care and communication. But did you know that residents with dementia are often more likely to become poorly malnourished than other residents? And did you know that malnutrition can worsen dementia and make the care and management of your residents even more difficult? For Mrs. Morse, something seems wrong. Food doesn't taste right to her. She's confused, so she chooses not to eat. Mr. Heckler is agitated. His caregiver helps calm him by suggesting that he get ready for dinner, because he'd be dining with friends. For Mr. Heckler, that is comfortable. It might even trigger memories of mealtime with family. Evoking familiar feelings may comfort him now and enable him to assist with his own care. As professional caregivers, you are in a unique position to observe your residents, to make sure that they are eating well, and to help them make sure the experience is enjoyable. You need two basic skills: understanding how to look for signs that your residents are not eating well, using your first-hand knowledge to find feeding approaches that seem to work best for each resident. If you've seen the previous program in this series, you understand the basics, the physical, emotional, and social declines associated with dementia. You see what residents experience as this disease progresses. You also see how dementia can affect your caregiving. There are many reasons why people with Alzheimer's disease and other dementias have nutritional problems. We'll focus on how aging affects our nutritional health, the ways dementia changes residents' ability to nourish themselves and enjoy mealtime, your role in screening residents to identify those at nutritional risk or those whose diet and mealtime experience is inadequate, what you can do to help residents get the nutrition and hydration or fluids that they need. We'll describe changes to the brain and body related to dementia and how they affect care needs as well as residents' ability to nourish themselves. Then we'll show you some simple things you can do to help residents eat and drink well to meet their nutrition and hydration needs. Your residents need an appropriate diet to maintain good health, to recover from illness, injury, or surgery, or to simply enjoy mealtime. Good nutritional status serves several important health benefits: maintaining health and preventing disease, appropriately complementing the treatment of chronic diseases, facilitating healthy recovery and improving outcomes after an acute medical episode. Nutritional health is a direct result of what residents eat and drink, but aging and disease change our needs and even the way we use nutrients. As we age, so does our body composition. Muscle mass decreases, fatty tissue increases, our metabolic rate declines, we see a progressive decrease in physical activity, and loss of lean body mass is associated with reduced function, such as slowed walking speed and limitations in activities of daily living. Loss of strength, endurance, and mobility places your residents at high risk for falls, weak bones, and decreased functional status. They are also more likely to depend on you for their physical and emotional needs. Our nutritional intake is also affected by our aging senses, as well as psychological and social circumstances. Residents suffering from dementia may lose short-term memory or the ability to quickly recall information received within the last 20 seconds. Many residents with dementia may lose their abilities to plan, to make judgments, to complete complex tasks, to understand what they see, and to speak or understand language. They suddenly become more dependent on others, and this, again, may cause them to react with sadness, frustration, and confusion. Is it any wonder that in this confused state, some residents may be uncooperative with you as you provide care? In the late stages of the disease, it is common for residents to lose eating functions. Decline in motor capacity and behavior interfere with eating. Nevertheless, eating problems can start with the beginning of the disease, along with a decline in the instrumental activities of daily living. People with dementia often need more energy. Their increased needs for calories may be caused by continuous wandering, increased time awake, fighting off infections, and healing wounds or pressure ulcers. Several other factors can interfere with good nutrition. Poor oral hygiene impacts hydration and nutritional status. Many medications can cause poor appetite and nausea. Be especially aware that many of the medications used to treat Alzheimer's disease can cause these symptoms. Psychiatric illnesses, especially depression associated with dementia, can reduce appetite and cause weight loss. Other symptoms of depression include expressions of hopelessness, worthlessness, and helplessness. When nutritional status declines, we often see a decrease in cognitive and functional abilities. Further, when residents with dementia are confused or upset about eating, they are more likely to display that confusion through hostile or uncooperative behavior. Again, consider the emotional impact on your residents. When they don't understand the act of eating or can't remember their last meal, they may be less inclined to eat or drink. They may not be interested in eating at all. We know that food and fluids are necessary, but several circumstances can inhibit residents with dementia from eating and drinking enough. By helping recognize signs that residents are not eating, you can identify the need to step up nutrition intervention. Before you can help your residents, you need to understand who needs your help. Nutritional risk refers to those signs that a person may experience problems with eating. By observing for signals and common markers, caregivers can stay ahead of nutritional problems and refer residents at risk for a more thorough assessment of their nutritional health. Nutritional risk screening is a formal process, but you already possess most of the skills you need to watch over your residents. Nutrition screening involves a few simple questions and observations. Has your resident lost more than 5% of body weight in the last month? Does a resident weigh less than 80% of desirable body weight? Do you observe your resident having difficulty swallowing food or drink during the meals, or have behaviors that mimic choking? Do you observe depression or a clear disinterest in eating? Does a resident refuse to eat 50% or more of 2 meals per day? Has your resident's nutritional intake recently decreased? Is your resident refusing to drink fluids? A yes answer to any of these questions suggests the risk of poor nutrition. This should be your cue to refer a resident for a formal nutrition assessment. Nutritional assessment is a combination of interview, physical examination, and laboratory test. While a formal assessment should be performed by your staff dietitian or physician, caregivers and family members are vital to the information collected. For nutritional assessment, No single measure is as useful as weight. Indeed, if a single weight value is of little interest, it can be compared to previous weights, computed with squared height to assess body mass index, and used in a variety of composite indexes. A standard, although well-calibrated weighing scale can be used. For patients with limited mobility, the use of a weighing chair, a wheelchair platform, or bed weighing apparatus may be warranted. Assess weight loss needs as precisely as possible. The period over which weight was lost is as important. A declared body weight is not acceptable. Malnutrition can be diagnosed for a weight loss exceeding 5% over 1 month or 10% over 6 months. Severe malnutrition for a weight loss exceeding 10% over 1 month or 15% over 6 months. Malnutrition is more likely to be associated with certain diseases like dementia. The number of different drugs they take may also increase the risk of poor nutrition. Starvation and/or wasting are more frequent in residents with dementia. As mentioned earlier, dehydration is also a concern. Suspect and report these signs of poor hydration: decreased skin turgor, dry mucous membranes, decreased urinary output, a change in bowel movements, especially constipation, changes in mental state or increased confusion, body temperature above normal or fever. Resident is having behaviors that are unusual or new to the resident. Other troubling signs include rapid heart rate or dizziness when standing up from sitting or lying down. Dehydration is a health concern, one that state surveyors look for when assessing your facility. One resident demonstrating signs of dehydration in your facility requires state surveyors to thoroughly assess that case and other aspects of care regarding fluid intake and nutrition. This can result in serious financial penalties and a ban on new admissions for your facility. Physical changes associated with aging with dementia can also affect patients' ability to eat and drink. Many residents with dementia suffer a diminishing sense of smell. This affects the way food tastes and the enjoyment of it. Recall the last time you ate a meal when you had a severe cold. Food didn't taste the same at all. When you can't smell food, food doesn't taste as good. Some residents with dementia may eventually lose control of the muscles that control chewing and swallowing. To assess swallowing, observe a resident for at least 3 meals. Look for excessive drooling. See if fluid leaks from the nose after swallowing. Watch for food that remains packed in the cheeks rather than swallowed. Difficulty swallowing can also be detected by the presence of a weak cough or gag reflex or the inability to cough. Your challenge is to help residents eat and drink in spite of challenges posed by dementia, poor memory, loss of smell, and the decreasing ability to swallow and feed themselves. It helps to know your residents, observe them, talk with them, review their charts, and make note of their nutrient requirements and special nutritional needs. Now you know the basics. What changes occur in most residents with dementia? Beyond that, everyone is different. As immediate caregivers, you know the most about your residents' needs and how they react to the world around them. You can encourage them by using this familiarity to engage them in eating, by working with their pleasant memories, by using routines that they are familiar with and that they are likely to find enjoyable. Maybe Mr. Roberts likes to sit at a table near the window. Maybe Mrs. Morse likes to begin her meal after carefully placing a napkin in her lap. Learn from them. What are the fondest memories? What foods do they like? What you know can help them and you.
Everybody's different. Their medical conditions are different, and the way they respond to treatment is different. So it's always a very individualized, patient-specific. You look for ways for approach. Sometimes a dementia patient doesn't want to be told what to do or doesn't know how to do what you're telling them. you find ways to get them to respond and to get them to be able to do as much for themselves as they can.
And if you don't know, ask. If they can share, ask your residents. If they can't, ask their families and friends about what foods their loved ones enjoy. What were their favorites from childhood? How do they like to have their food served? Some people like soup from a cup, for instance. Find out what sorts of pleasant memories from long ago that they have, like preparing for a party for children or eating out with friends. Once you learn these things, you can carefully try to add them into the routine for each resident. Residents, especially those with dementia, may not respond clearly to routine questioning. Aided awareness can be more helpful by asking pointed questions or merely observing them in social situations. When we observe and learn what works for each of our residents, we can use that knowledge to treat confused residents in a way that will limit behavioral problems like aggressiveness. Let's talk about what you can do, how you can help to make sure residents with dementia eat well, drink enough, and achieve their nutritional goals. Residents with dementia especially need to be kept safe and secure. Guidance and cues, appropriate stimulation but not too much, to limit changes. Sometimes any changes may be stressful for them. Start by finding the familiar. This will set the comfort zone for your residents. Associate snack and meal times with familiar events from earlier in the resident's life. This connects eating today with an understandable and familiar activity for the resident. Let residents know that a meal or snack is coming by giving them napkins to handle or maybe having them set the table. Have them wash their hands before the meal. Help them anticipate. Show and let them smell or even touch cooked food. Allow them to use different senses to connect familiar items to memories. This can help to make mealtime and eating understandable and familiar, and residents will be less likely to resist. The dining environment should be pleasant and table settings should be attractively set, yet appropriate for the resident. Bright china, especially red china, has been helpful in improving intake in some patients with dementia. It helps the resident identify between the plate and the table, which allows them to see the food on their plate. China with patterns or colored rims should be avoided, as these can be distractions during eating. Residents often spill food on themselves while eating. Some residents may be confused or embarrassed by a bib. Remember that they don't recall that they are ill. Instead, suggest to women that a kitchen apron is a good idea, and for men to try a barbecue apron. Again, find a substitute that is familiar and understandable to residents. Use other events during the day as eating occasions. Work with the activity director to have snacks served every day during activity time. Encourage finger food snacks that are easier for the resident with dementia to eat. Usually, drinks, snacks, and meals are delivered on a nourishment cart. This is an unfamiliar item to most residents, so it will possibly confuse or even frighten them. Turn this time into one that is pleasant for residents and staff. Since residents often eat dessert first at meal times, save the dessert to serve at snack time instead. Use a restaurant tray or a tea cart to present items. Just like in movies, props can call to mind a familiar time or a place or memory. If you can guide and direct, residents can enjoy serving the desserts and drinks to one another. Instead of something unusual and disorienting, this becomes a familiar, understandable social event, and it more pleasantly meets the need for food and drink. Make eating occasions familiar and routine. Avoid confusion that can occur when routines are different. The dining process should be calm and unhurried. Limit noises and distractions. If someone is overwhelmed, give them one food at a time. Be sure foods are not too hot or too cold. When possible, have more highly functioning residents sit with lower functioning residents. They can encourage other residents and model eating. Seeing and hearing others may help cue others to eat.
You're in a dining setting. You're in an environment where everybody else is eating. Sometimes if patients are eating in their rooms or they're in their bed, they tend to not want to eat. They're in bed or they're wanting to get to bed.
It gives them a chance to get out of their rooms and socialize with other residents and interact with staff members, besides the ones that are regularly assigned to their hallway. It gives them a chance to see other residents and sometimes family members when they come in a more home-like environment.
When assisting with feeding, sit down beside your residents. Take your time. Proper positioning for swallowing involves instructioning the resident to sit erect, leaning slightly forward with their head also flexed forward. Instruct residents to open their mouth and feel the food on their tongue. For residents who have had a stroke, place food on the unaffected side of the tongue with a spoon. Once they have food in their mouth, instruct them to taste the food. Chew, put their chin down, and swallow. Alternate foods and liquids. After swallowing, the resident should be instructed to swallow again to make sure that their throat is clear. Keep in mind that fluids may be more difficult to swallow than solid food. These should be administered cautiously and according to the dietitian's and speech therapist's recommendations. After eating, keep the resident in a sitting position for at least 15 minutes. Talk about and prompt for eating, chewing, and swallowing. If forks or spoons are hard to use, offer residents appropriate finger foods. If necessary, cut food into small pieces. There may be times of day when residents are less confused. Try to arrange mealtime for those moments. Breakfast may be the best meal for some, lunch or dinner for others. Also, use that time to provide additional foods or encourage them more. Nutritionally dense or enhanced foods may help provide more caloric intake when needed. Poor teeth, lack of or poorly fitting dentures, mouth pain, and inflamed gums or tongue all impact negatively on nutritional status. You can also help residents overcome these challenges. Obtain a dental consultation as indicated. If oral hygiene is poor, encourage or provide mouth care before each meal. Make sure that dentures are used and fitting well. Solid bright red or orange plates may be better than pale or patterned plates to help residents find foods. And for some, a bowl may work better than a plate. Residents may also benefit from adaptive utensils, plates, and cups. Ask a dietitian to help pick foods, drinks, and snacks which are appealing and appropriate to the ability of each resident. And whenever you can, encourage eating and drinking. During feeding and any activity, try to focus on residents as well as the task you are performing. By closely observing each resident, you'll find valuable clues about each person that can simplify your work. For example, you notice that Mrs. Morse reached for a napkin for her lap. Now you can cue her that it is mealtime by handing her a napkin or helping her place it in her lap. Finally, if you do see changes in behavior, tell the nurse. These changes can be important signs that residents might need special care or accommodations. Residents with dementia do better when all or most of their time is structured, spending it in activities directed by staff rather than being left to their own devices for much of the day. This approach also lets residents function to their fullest, enhances family satisfaction, and enriches the lives of all. Your role is crucial in developing and directing these programs because you know your residents the best. We've shown how residents with dementia can benefit from steady and regular routines. Often a structured day or structured programming can also provide some familiarity and comfort. Structured programs often include 4-hour blocks of 30-minute activities. Experts have found that developing, using, evaluating, and continually revising a structured daily program can reduce the stress and cost of providing care. Let's look at a structured program. This one is designed to make snack and meals enjoyable and to encourage eating. Breakfast. Residents are prepared for breakfast and dine from 7:15 a.m. to 9 a.m. The nursing assistant sits with residents, giving direction, cueing residents to eat, and helping those who need more assistance. Nursing assistant talks to the resident during the mealtime about things relevant to the resident, not other staff. Residents sit together. Better functioning residents are encouraged to give verbal directions to other residents. Other familiar activities from residents' previous lives are helpful as they end their meals. For example, women frequently will leave the table carrying a cup, dish, or silverware in order to begin washing dishes after the meal. This habitual behavior can be useful. Place dish pans of warm, soapy water where they can wash the dishes. The end result will be that the residents will rinse some food off of their hands, lessening the cleanup needed from nursing staff. In addition, they will be involved in a meaningful way in their daily living. Above all, remember that mealtime should be pleasant and enjoyable. That enjoyment is tied into a relaxing and comfortable atmosphere, as well as foods that residents desire. If you can, offer residents choices or select foods that you know that they like. Mealtime is also a social opportunity, a chance to be with friends and visiting family. Even if residents with dementia have trouble communicating, talk with them and understand that they will probably appreciate being around people that they enjoy. No matter what the activity, keep residents involved. Engage them. Help them to find enjoyment in their own lives, to live fully in each moment.
You know, if there's something's being served, they remember that their mother used to make, or that they used to get at a favorite restaurant. We talk about recipes, working with memory, trying to get them to remember how to tell a recipe. I'll write down what the recipe is and, you know, make it functional, like I really need the recipe or really want it.
Allow the resident to reminisce about the past. To those with dementia, the current day-to-day events in the city, etc., are not that important. These moments may seem small, but can bring a sense of well-being to a life that is all too often confusing. A good dementia unit does not use the use of TVs unless it is for musicals or old Lawrence Welk videos. Residents with dementia cannot follow a storyline, so this makes TV shows and movies only frustrating and does not engage them. Do not focus on TV as an appropriate activity on a dementia unit. Music is a great intervention for the resident with dementia and can be very successful with decreasing unwanted behaviors. Do not play music during mealtime, as it can be distracting and takes them away from the activity of dining. Music should be used outside of mealtime to songs that the resident would enjoy, not the staff. The more you can help residents find familiar ways to connect their memories and experiences to today, the more you can enrich their lives, make families happy, and decrease the stress and workload of caregivers. When it comes to good nutrition, your simple actions, your careful observation, and your kind intervention will go a long way to help residents enjoy meals and mealtime.